For those of you that have not had the privilege of meeting, my name is Tim Millea. I'm de facto president of the guild. I'm just the show horse. Dr. Michael Perubshin back here is the brains of the outfit, and I get thrown in front of the crowd. The guild's been around for going on 5 years now, and there's information back in the back table about the Catholic Medical Association. But if you just Google Thomas Aquinas Guild, you'll find our website. Information you need is there. And if you Google Google cathmed.org, that's Catholic Medical Association. So not to get into too much detail, we have a fair amount to cover today. I'm just very grateful that you came. I heard a joke the other day. I'm an orthopedic surgeon. What's the difference between an orthopedic surgeon and a rhinoceros? Well, one has a small brain, thick hide, and charges a lot, and the other has a horn. So I thought that was pretty good, actually. So, anyway, this is a topic that I really kind of snookered myself into. I did a talk last September at the CMA National meeting in Dallas, kind of around just a spiritual look at burnout. And we'll talk about burnout itself. But today, I've already given myself a grade on this talk. It's a D. I'm going to give myself a D because everything I want to talk about starts with D. We're going to go through some definitions. Those of you who don't have coffee, get some because we're going to cover some data. The stuff we're talking about as a problem it's not objective, it's not really measurable, but it is. There's a surprising amount of data about this issue. Discouragement. So I'm going to take you down, and we're going to try to figure out what do we do about it with a dilemma. Do a discernment type thing about, okay, so this is where the problem is. This is the choices we have. How do we get out of this pickle? And then the decisions, and finally the determination about moving forward. So the first definition I want to talk about is this. Okay, so what's happiness? And there are certain terms here that are, as I say, non-scientific that I'll be talking about. So if you go to the dictionary, Merriam and Webster, well-being and contentment, pleasurable, satisfying. What I want you to remember, keep in mind, is this part, the well-being and contentment. Go to that one. There it is. Okay. All right, so if you're St. Philip Neri, this is really not what we're talking about. Of course, it's easier to move somebody along in their faith who's a happy, kind of a happy, clappy person rather than somebody who's got that Eeyore personality. That's different than what we're talking about. Padre Pio gets a little bit closer, talking about, which I can't see, it says, joy with peace is the sister of charity, serve the Lord with laughter. Those of you who work in health, doesn't matter that you work in healthcare or not. You know that person that comes to mind immediately. If somebody says, think of the person that you can't believe they're happy all the time. I mean, they are just as happy as can be. They're contented. They may have a lousy life on the surface, but they just have that inner joy. That's what we're talking about today. As John Paul, God made us for joy. Okay, so now we get to burnout. Another good cartoon here too. I love this. I feel the way you look. So once we get, first we got to figure out what are we dealing with. Now I want to make one statement here too that most of the data that I'll be talking about, a good amount of the data, maybe not most of it, relates to physicians. However, you see more and more information as time goes by about this particular concern in all layers of healthcare, all the way down. The nursing literature is starting to show more of it. So it's the entire team that's involved with this. And all of the stuff that goes with it, all these little words around it, there's a whole, what I consider to be kind of a vague description. So next definition, what is burnout? Well, the one that you hear most commonly is this: exhaustion, cynicism, and decreased productivity. I feel that way after Notre Dame plays Clemson, or Alabama. I mean, I'm done. I don't care anymore. I just don't want to do anything. So, I mean, that's kind of the way that it's been described in most literature. A term I came across about a year ago that I thought was good is gone, right there, compassion fatigue. All right, you care, you give, to the point where it just wears you out. And even there is a website, Compassion Fatigue Awareness Project. The one that I really like is this bottom one, moral injury. And the original description of it in 2009, this was a paper about war veterans, Iraqi and Afghanistan war veterans, that are trying to reconcile themselves morally with what they did in combat. But if you could translate that to the moral injury of healthcare, being unable to provide high-quality care and healing in the context of healthcare. So keep in mind high-quality care and healing in healthcare. So symptoms of burnout. You name it, it's there. These are basically not reading through all of them, but you not only do you know that person that's joyful all the time, but you know that person that is the exact opposite. You're looking at the 180-degree difference. And I mean, some of us at all points in time, some of these things come into play, but as you go down, particularly into the behavioral part of all this, that's what is obvious if you see someone in healthcare at any level of the organizational chart that is really at wit's end, is really having a difficult time struggling. And I would maintain that this diagnosis, these symptoms have been present for 2 centuries. These are in Galatians, when the flesh sets its desire against the spirit. This is the description in the letter to the Galatians. And if you look at that side by side with the symptoms of this moral injury, this burnout, drinking bouts and jealousy and hatreds and licentiousness and all of that, it all kind of fits together. All right. There is basically an online resource for physicians called Medscape. And Medscape is known for sending out little newsletters online and all. But every year they do a physician survey. And it can be a survey that includes, compensation, careers, what's your specialty, all that. Over the past several years, they have included a portion of their survey. This is just not an online survey, so it's certainly not exceptionally scientific. But the information, the volume of information they got more than 15,000 physicians in multiple specialties answering this survey. This is the first year that this part of the report included the word depression. Several years ago, it started with burnout, then it became burnout and suicide. They put depression in there too, which I think is a reflection of how vague the description is. We got 44% of docs in the country saying, I do. And that list of symptoms, if you're giving me that definition of burnout, that's me. 44%. Among female physicians, half of female physicians will describe a problem with burnout. 39% of male physicians. Which ones are most burned out? Well, what's distressing here, it's not so much the specialty, it's just every specialty. And in general, the ones that are, I think this is a reflection of surgeon's personality, That's different. That's the other joke. The difference between God and a surgeon is God knows he's not a surgeon. But so, the surgical specialties tend to be in the lower part. The non-surgical specialties tend to be in the upper part. What I think is interesting is the very bottom one, public health and preventive medicine. That's the only one of these specialties that is proactive. Everything else is reactive in medicine. So the people that are saying we're going to do what we can to keep you healthy are the ones that don't have as much of an issue. What kind of environment do they work in? Those that are employed physicians, the very top, have the highest level. And here's the Mavericks, here's the Rangers, the guys still out there fighting the battle, solo practice, have the lowest, but still 41% of them have that complaint. What makes it happen? I think any doc here in the room, anybody in the room that works with a chart, you know what I'm talking about, okay? It's the top one, it's the paperwork, it's hours at work. Insufficient compensation is less than half of the paperwork part of this. And this isn't the patient's fault. Only 16% say it's a lack of respect from patients that makes me feel this way. It's the bureaucracy, it's the paperwork. How does it affect the way you deal with your coworkers? Well, no big surprise, and we all know that person too. The person that just flies off the handle right away. I think the 29% in the middle, it doesn't affect my behavior in the workplace. It's either denial or a lie. We'll come back to that too. How does it affect your patient care? I think the 47% at the top there, I think that's a denial or a lie too. If you are not at your best or near your best, if you're being negatively impacted by the way your work is affecting you, you're not giving it's not a maximal effort, patient care. If you're not at your best, I don't think you can give your best. And that goes to this study. This is from Greece. I know nothing about the Greek medical health, the healthcare system. But this is about the only paper that's really looked at the relationship between physicians and patients and how does that affect the patient's satisfaction with the doctor. So here's the basic bottom line with this. Direct significant correlation. If the physician is emotionally exhausted, depersonalized, just feels blah, angry, upset, frustrated, there's a direct correlation. The higher that goes, the satisfaction rate drops. And how they came up with this, I tried to read the paper, and here's another great joke. It was Greek to me. A third of the patient's satisfaction, their level of satisfaction related to the physician, the behavior and the interaction. And bottom line here, physicians with high exhaustion, high depersonalization, those patients had significantly lower satisfaction scores. Does that make sense? Of course it makes sense. You're going in to see, Dr. Grumpy Pants. You're not going to come out of there feeling just, like it's Christmas morning. You're not going to feel that way. Okay, here's another example, I think, of denial or lying. Probably more denial. Do you plan to seek help? Almost 2/3 said no, and I haven't done it in the past. Is that troubling? It's just, now some of that is ingrained in us, going back to pre-med and medical school and residency. You don't complain, you suffer in silence, you just do the work and, do your job. But again, I'll go back to the point I made a moment ago. If you're not at your best, you can't give your best. Okay, now, a couple background points with this, and I promise we'll get over the data here. Actually, as I look at my slides, no, we got data to go yet. Okay, Medscape did a survey back in 2012, and a little more than half of physicians would say they would go into medicine if they had to do all over again. The year before that, it was 15% higher. What happened? 2011, 2012. There you are, Affordable Care Act. My first CMA meeting was in St. Paul, Minnesota in 2011. And it was double the attendance they expected. Best recruiter for the CMA was Barack Obama. And everybody was ready to go. This is to the point now where this is the logo for an online service, online organization called the Dropout Club. And the Dropout Club has a website called docjobs.com. Docjobs.com is where physicians that say, done, I'm not going to do this anymore. It's a recruiting site for jobs as consultants in industry, working in the markets, being advisors to pharmaceutical companies, getting out of the clinical environment. There have been at least 50,000 doctors that have been on this website. And then this goes back several years ago. But in the ANA Journal, a consensus statement, this was really kind of I like the term they use, physicians are the canaries in the healthcare coal mine. At that point in time, here we are 16 years ago, suicide rate among physicians was more than twice that of active duty military. So if you're a physician, and the suicide risk is twice what it is for guys and gals that are dodging bullets. That's a problem. I promise I'm not going to rain on everybody's parade today. So, How do they cope with burnout? Okay, some of the stuff makes sense, except the 41% that say, I'm done, I'm just going off by myself, I'm going to shut the door. Almost a fourth of them, alcohol, and marijuana way at the bottom, but you can see people's reactions to stress depend upon the individual. And a subset of the Medscape study, now this is from 2018, this question was not posed in the 2019 study, but when do you use any religious or spiritual beliefs to help yourself cope? Almost 3/4 said, I do. Okay, so there's a little glimmer there. And out of that 3/4 of 3/4 say, those beliefs help me cope. And I think that's something to hang on to. I think that's just a little glimmer that there's something you can. You can make the not Thomas Aquinas. I just like using his picture, but that sense, that inner morality, that something's wrong, and there's something good, but it's buried so deep under all the clutter that you can't get to it. So, if we look at the religious affiliation of docs in the country. And this is still pretty stable from Kurland's study, the University of Chicago study. And by and large, about 40% of American physicians are Protestant. About 20 to 22% are Catholic. Jewish. I just love this. I have a good friend of mine who's a Jewish physician, and his mother, my son the doctor, my son the doctor. It's not my son, it's my son the doctor. And just that 14% of physicians, but 2% of the population. And then the nuns. We're all familiar with the nuns. So the numbers are small. They're vocal, obviously, when it comes to particularly the atheist community. In this same study, though, and again, this is kind of the glimmer I want you to think about, more physicians than the general population will say, my religious commitments have an impact on my daily life. And I think that is something that is at least underestimated. It's certainly not visible as much as we'd like it to be. This adage that I'm spiritual but not religious, kind of the New Age type of a belief system. Physicians don't buy into that as much as the general population does. And I cope with problems in my life without relying on God. Much less likely that physicians would agree with that than with the general population. So there's that spark. There's that spark in there it's not the flame it maybe should be. This study in 2003 looked at what are the factors that help a patient and the physician together make a decision. So, faith in God. Patients rank it number 2. Behind, I think number 1 was confidence in the physician. Other than our good friend Dr. Peruchin, that was ranked last by oncologists. People that are dealing truly with life or death issues. And that particular thing was ranked dead last. So nobody's happy, right? Well, this guy isn't very happy. If I can get his picture up here, that guy's not happy. So if the docs are feeling this way, and the nurses, and everybody you're working with is just grinding, and they're just that bleak, overwhelming sense that I don't make a difference, I'm not happy at doing this. Okay, well, look at the other side of the fence. Top 5 complaints that patients have. I wait too long. I can't get on the schedule. Doc, nobody's listening to me. Not enough time. And billing and insurance. Okay? Those are the 5 top things that patients tend to complain about. So we've got this toxic mix. We have somebody who's going to work to take care of people that really doesn't feel up to it. And we have a patient that just seems to be on edge. They just know that this stuff's going to happen. They're going from the frying pan to the fire. Okay, so is there good news? Yeah. Welcome to heaven. Your luggage is going to hell. So, okay. We've pretty much taken care of the definitions. We've taken care of what are the problems here? I think we've got that. All that data. Thank you for bearing with me on that. I hesitate to put this up here. Anybody here working in administration and healthcare, please don't take this personally, but I take it personally. This is an online blog, and there were 10 CEOs of large healthcare systems that put this together. And this is their advice to their fellow CEOs about how do we deal with this burnout issue. I'm not going to read them all, but I want you to focus on the red letters. I think I got one more right there, okay? And just some key phrases: benchmarks, metrics, institutional cost, allocation, collaborative, my favorite, stakeholders in the healthcare ecosystem. You take out anything that says healthcare here, this could be from John Deere. This could be any place that puts widgets in boxes, okay? And I think there's that disconnect that it's nobody's fault really, it's just a different perspective. The administrators are looking at it from a different perspective than the physicians. This is more happy clappy, but I like it better. The Institute for Healthcare Improvement. The task force with them back in 2017, framework for improving joy in work. And they're not talking metrics. Ask staff what matters. What keeps them from feeling happy in their work? Make it a shared responsibility. Just like everybody is going to help take care of the patient. We're all in on this. It's a team effort. What can we do to keep each other content with this? And what are the strategies that improve that sense of joy and contentment? And then basic categories of how do you get to that point. I won't read through all of these. This is a little bit more like an HR type thing, but it's an HR type thing. I think back to the hospitals where I grew up at. The biggest hospital within 50 miles of my hometown was about 30 beds. And no matter when you walked in, you knew everybody. And everybody knew you, and everybody was on the same page with that. So it's easier to do this type of stuff in that smaller environment, but that doesn't mean it can't be done in a bigger environment. Okay, so now let's get on to we pretty much identify the dilemma. What do we do about the discernment, and how do we get this thing figured out? You're all familiar with the Gallup organization, the polling organization. So in 2012, the editor-in-chief of Gallup authored his own little review and he titled it "God is Alive and Well." It was a poll, a random poll of American citizens about religion, basically religion, trying to tease out. And some of the data that you saw about Catholics versus other religions was in that study. But if you get your hands on this and you read it, you certainly get the sense that, it's not as bad as it seems to be. It's not great, but this was kind of this was the elevator speech from that white paper. Americans who are the most religious have the highest well-being. You go back to the definition of happiness at the beginning. Contentment, a sense of contentment and well-being. If I can recommend one book, this would be the book. Those of you who are familiar with Bill Donahue, I can tell you, Bill Donahue, it's essentially impossible to find a picture of him smiling. He's the president of the Catholic, or executive director of the Catholic League, oftentimes known as the American Catholic Bulldog. You'll see him on talk shows, you'll see him on the news being interviewed. And the guy, he pulls no punches. This guy is serious. However, his background, he's a PhD in sociology. So he's very tuned in to the kind of things we're talking about today. How do people act? How do people react? And there's a comment in his towards the end of his book. Well, first off, the content of his book, you can break it down. He introduces this right away, then he gives his data for why. 3 B's of Catholicism: beliefs, boundaries, and bonds. 3 H's: health, happiness, and heaven. So that's basically the take-home point from this book. But in that, he makes this statement too. We cannot make people do this stuff. We have to make sure they know it's available and they're allowed to do it. Jesus doesn't twist our arms. He extends his. So to build on that stuff, most of this stuff now is coming from Donahue's book. Simple happiness survey. Very happy, happy, not so happy, unhappy. Those who attend across the board any particular religious belief, weekly services or more frequently, 43% are very happy. Monthly or less, 31%. Never, 26%. Okay. Everybody here's happy, right? They're very happy. Capital letter happy. I love this paper because it's so simple. It's truly anecdotal. When I showed this at the national meeting in Dallas, I told everybody this is why you need to move to Iowa. This was an Ohio State group that did this study, and what they did, they looked at newspapers. They looked at obituaries. Simple question: is there a church or a synagogue, any religious affiliation listed in the obituary? That was the only thing they looked at. And if you look at obituaries, those that have them and those that don't, about a third of the study was obituaries from Des Moines. The rest were from around the country. People with religious affiliations in their obituary have lived longer, especially in Des Moines. I think in Davenport it's like 15 years or something like that. So, but anyway, I mean this is part of that whole happiness quotient. And this, I think, just because of the number of subjects and the data that it shows, I think is one of the most important factors to support a religious belief system, a committed religious belief system that prevents this moral injury, this burnout thing. Nurses in the prime of their career, almost 90,000 of them, if they go to a religious service, all religions, once a week or more, they have an 80% lower suicide risk than those who don't. Female nurses who identify as a Protestant, 7 times higher suicide rate than nurses who identify as Catholic. And why they couldn't find one more Catholic woman, I don't know. But you think about the odds. You've got 7,000 women who go to Mass more than once a week. Not a single one of them took their life. But if you have a woman who says, yeah, I'm Catholic, but I don't participate, I don't do anything with it, suicide risk is the same as a female nurse who has no religion, atheist. So you take that as an indication of just how important this affiliation, this activity is. And if you look at just the job satisfaction, 12 years ago, almost half of Americans were very satisfied with their job. Smaller number would describe themselves as very happy. The highest rated happiness on the job is clergy. Number 2 is physical therapists. Any PTs here? Yeah, where's the, yeah. My wife and I were both PTs back when Lincoln was president. So, but number 2 is physical therapists. Number 3 was firefighters. You think those guys are out there busting their fannies every day. They're putting themselves at risk, but the satisfaction they get from their work, that's the key with this. So as a follow-up to this, Monsignor Rossetti, a few years later, did a survey of priests from around the country. 87%. This goes back to Donahue's beliefs, bonds, boundaries. A sense of inner peace because of my beliefs. 90% bonds. They feel connected. They feel important to others, that community feeling. And 92% of our happiest priests, the inverse relationship between narcissism and religion. Priests have a very, very low score on narcissism scales. And think about Hollywood, okay? Think about celebrities. Narcissism, right? Yeah. Religion, way down there. So the inverse relationship between those two. Okay, so we've looked at the disease, all right? This is the disease. As Paul wrote to the Galatians, if you're really not doing what you should be doing, if you're not following the not appropriate behavior, you're not following what Christ has taught us, this is what's going to happen. Okay, immediately after this, the next verse is the cure. This is the spirit acting against the flesh acting against the spirit. This is the spirit working, improving the flesh. So all of those factors. I mean, you think about that person. You think about that person that is happy all the time. And you're going to use words to describe them. That right-hand column is right there. That's it right there. That's the goal. So from the original Latin, ligare, to bind, religion, to rebind, that's what is really kind of where I want to go with this. And we don't have any better teacher, any better instruction than from church history. St. Basil of Caesarea in the 4th century, what would be considered the first hospital. This is just the remaining ruins of the building that housed what's become known as the first hospital. You're not taking care of people in their homes. You're not letting people just die. You're actually caring for people. So we've got 1,600 years of history with this. And it's not just Basil. You can go through the history of medicine from St. Luke. You've got St. Elizabeth of Hungary, Catherine of Siena, and some that you may not know. Perret, who was really one of the fathers of vascular surgery. Morgagni, who is really the first pathologist, the father of pathology. Galvani, this is for an orthopedic surgeon, XPT. This is the guy that first described the electrical activity of muscle. Why does muscle move? Well, there's electrical activity. And I love the, it's kind of hard to see, but those of you that took high school biology, those are frog legs. He's stimulating frog legs, okay? And more recently, O'Dwyer, an American physician who really was the guy that developed intubation, going to put a tube down. You know? And I think the one that we're probably the most familiar with, Jérôme Lejeune, the French geneticist, the father of modern genetics, clarified the correlation between the chromosomal abnormalities and Down syndrome. Became a strong anti-abortion voice and was shunned. Basically, the pediatric academies would have nothing to do with it. He gave one talk at a meeting after he had made the connection with Down syndrome, the chromosomal abnormalities, and made a pitch for saying, we got to be careful. We can figure this out. We know which baby is going to have Down syndrome, and people are going to want to kill babies. And that was in the 50s that happened. So he just passed away about 20 years ago. All of these are Catholics, practicing Catholics, devoted Catholics. So to make the whole situation new, where do we go from here? This is where I want to get into. Basically, here's where we are. Here's where we've been. Here's where we are now. Where do we go from here? I can't think of a better word than true for hospitals and healthcare systems that are not just Catholic in name, but Catholic in philosophy. If you hear a phrase called ERD, or the acronym ERDs, Ethical and Religious Directives. The ERDs are established by the Catholic Church, and basically everything that you would think would be a Catholic healthcare value is included in that. So ERDs, hospitals and healthcare systems that are ERD committed, they're kind of like unicorns right now. You know, you want to hear about them, but you don't see them. But I think there's going to be that is going to change. Catholic-centered clinics. Again, clinics that are devoted to the ERDs. People that are going to work there, in these hospitals, in these clinics, that share the same thing. Everybody's in. Here's the team. And most importantly, this is the cog. We got to have people that expect it. People that want this. They want that person that can come in that examining room and just sit down, shut up, and listen and not worry about, or you tell me again, what happened? Never. The only reason they know your face is because your ID is up here in the corner of their screen. That's the only way they recognize you. Now, let's don't get carried away. Years ago, about a decade or about a century ago, Padre Pio had this vision, what he called the House of Suffering. And it was just going to be a nice, tidy little place for people that, didn't have anybody take care of them. They were indigent. They just didn't have family. That's what can happen. This entire complex is huge. It's on the side of a mountain. This has become the Padre Pio, the monument to his belief in taking care of other people. It can be much smaller. Those of you who are familiar with the National Gianna Center, I probably shouldn't steal the thunder. Women's Choice Center is affiliating with National Gianna Center with the new primary care clinic being developed in their new building. And this is a truly ERD focused, and it's not just women's health and fertility. That's their emphasis when they started up in the East Coast, but it is becoming primary care in general. And then Common Spirit is a recent development. This is 13 different religious organizations that have a healthcare system, various religious orders that have combined into this thing called Common Spirit. Now, nothing blatant that, okay, we're going to be Catholic, we're going to be truly Catholic, we're going to be ERD following. No statements, but it's been relatively early with that. Now, I wanted one last topic to bring up here before we close. So, the general vision, I hope you got a sense as to what I'm talking about. I've been in this rodeo for quite a while, and now that I'm later in my career, I always tell patients, you don't need surgery because my kids are out of college and my daughter's weddings are paid for. I'm good to go. So I get the chance, and I have the privilege and frankly the luxury where I can just shut up and sit down and listen to people. And what's really captured my attention is some physicians I've met from around the country that are involved in what's become known as direct primary care. Now, this is not concierge care. There was the TV show, one of the cable channels, the guy on Long Island who's the call the doc, for the rich people. Okay, that's not what I'm talking about. Direct primary care. If you do a survey, this survey was of the DPC providers, docs that were doing that kind of work. Less than 10% had a feeling of burnout. You've got 44% that don't work in this kind of environment that feel that way. More, 2/3 would tell their kids medicine would be a good career. I think you should consider that. This is the one that got my attention too. Time spent on paperwork, dramatically lower paperwork, and we'll come back to that explanation. And my favorite stat, 79%. I have all the time I need to take care of people. I don't feel like I gotta just point, click, go. I can take the time that I feel my patients deserve. So the direct primary care model basically is this. Standard system, fee for service is what you see on the right. You got a doctor and a patient, but for that doctor to help with that patient, you gotta go through all these different steps. Direct primary care is exactly what it says. I got a doctor, I got a patient. Patients typically, the usual model is they pay a monthly fee and they can come in same day. They have the doctor's cell phone number, they text them, they email them, and I've not yet met a DPC doc that says they don't love it. They love it because they feel like, and this is all primary care, it's kind of a hard model to work for specialties, but the other layer to this that relates to what we're talking about today, recently, a group of us went up to Madison, Wisconsin to visit a gentleman we've come to know. This is called the Our Lady of Hope Clinic in Madison. And in Madison, our friend Mike was recruited by a group of Catholic families to start a direct primary care clinic. And the members of the clinic, his patients and their families, they pay a monthly fee. But they are told from the beginning, before they pay anything, part of your money is going to help care for indigent uninsured. So they will provide services to indigent uninsured, those who are between jobs, don't have insurance, and they are truly following that ERD, taking care of the poor, taking care of the orphan, the widows, whatever it may be. from the, if you want to look back in an Old Testament means. And it's a small clinic, but at that CMA meeting that I mentioned, I'm on a committee with the National Organization for a Catholic Clinic Development Committee. And just kind of a spur of the moment, anybody who's interested, we're going to be in this room, at the end of the day when the meetings are over. We had 40 to 50 different people show up. I mean, some of them, multiple people from clinics. And as this has gone forward, the enthusiasm, the interest, and I really think the commitment for it is very underestimated. There's a mojo. I mean, there's a motivation for this. Okay, so that means that if we're going to be like St. Luke and all those other fancy pants historical doctors, we all need to be nuns or priests, right? No, we don't have to. Those of you who heard Sister Mary Diana Drager, our Nashville Dominican friend, when she did her White Mass talk here a few years ago, she's internal medicine. She was in the convent. She was a high school math teacher, became Dominican, and ended up going to medical school after that. She works in an indigent care, in a healthcare system, in a healthcare corporation, but an indigent care clinic that they are financing in Nashville. Father Scott Francis Benet is a priest. He's originally from the Twin Cities, but he's been doing medical mission work throughout the Southeast and Latin America for many years, and now he's establishing a clinic in South Carolina along the same lines as what we're talking about in Madison, to really take the healthcare to that periphery. But his practice, as it stands now, will be a DPC type practice as well. So rallying the troops, I mean, this is all stuff that, God willing, it happens, and I'll be dead and gone, but I want to die with somebody like these guys and gals taking care of me. So this is from the CMA meeting we had in D.C. a couple years ago at the National Cathedral. And just that groundswell, this is not a recruiting call, but the applications are on the back table. But the reason that I continue to go to these meetings and do this kind of stuff is because it's there. It's that spark. And I really want to be part of the gas tank that get thrown on that spark to move things along, because we can do a lot better than we have been. And I think if we take a non-medical, non-scientific approach to this and we look at the truth of the matter, the information is right in front of us. Part 1, Section 1, Chapter 1, the Catechism of the Catholic Church. Desire for God's written in the human heart. God never ceases to draw man to himself, and bingo. Only in God will he find the truth and happiness he never stops searching for. That's the faith, and this is what the action is that's required. So that, in addition to all the other stuff I've blabbed on about here, this is really the primary take-home point. So can you be unconditionally happy working in healthcare? All right. Think about the worst environment. Imagine the worst environment you can work in. Imagine the patients, the worst patients. You can hardly even imagine being close to them. And think about the rewards that you get are nothing. You get no material rewards, no physical rewards. Can you be happy? Of course you can be happy. You can be happy by doing this. So, everybody, okay. Thank you all very much. I appreciate your attention. Thank you.